The malignant tumor of the salivary glands includes the adenoid cystic carcinoma, mucoepidermoid carcinoma, acinic cell carcinoma, or adenocarcinomas. Now let us discuss them one by one. The first is the acinic cell carcinoma. It is also known as acinar cells or serous cell adenoma. So it is a malignant epithelium neoplasm in which neoplastic cells express acinar differentiation. So what you will see is the acinar differentiation. It has a low grade malignant potential. It is the third most malignant salivary gland tumor after the mucoepidermoid and adenocarcinoma. By the conventional use, the term acinic cell carcinoma is defined by pathological differentiation toward the serous acinar cells, whose characteristic feature is cytoplasmic, positive, zymogen type secretory granules. So these are the acinic cell carcinoma. It closely resembles to the pleomorphic adenoma in gross appearance. It occurs chiefly in the parotid gland. It does occur occasionally in other major glands and in the accessory intraoral glands. The most common intraoral sites, they are the lips and buccal mucosa. It is generally seen in 44 years. Women are more affected than the men. Along with the pain, you will see the muscle weakness, the facial muscle weakness may be seen. Now, what are the histological features of this? The acinic cell carcinoma, it is surrounded by a thin capsule that may be composed of varying degree of differentiation. Well differentiated cells bear resemblance to the normal acinar cells, whereas the less differentiated cells will resemble embryonic ducts and immature acinar cells. Four type of growth pattern may be seen. They are solid, papillary, cystic, follicular, or microcytic. The most characteristic cells seen has a feature of serous acinar cells with abundant granular basophilic cytoplasm and round dark stained eccentric nucleus. There may be seen intercalated duct-like cells that are smaller and are vacuolated. The treatment of acinic cell carcinoma is mostly surgical. Next comes the mucoepidermoid carcinoma. The mucoepidermoid carcinoma, it is the malignant epithelial tumor. So it is composed of both mucus secreting cells and the epidermoid cells. It is the most common malignant neoplasm observed in major and minor salivary glands. Parotid gland is the most common site of occurrence. Intraorally, you will see the most common involvement site is palate, then buccal mucosa, tongue, and retromolar area. It is generally seen more in females around 3rd to 5th decade of life. Which one is the most common malignant salivary gland tumor of children? It's the mucoepidermoid carcinoma. Prior exposure to the ionizing radiation appears to increase the risk of developing mucoepidermoid carcinoma. It arises from reserve cells in the interlobular and intralobular segment of salivary duct. The tumor of low-grade malignancy has pleomorphic adenoma-like features, like it is slow, enlarging, painless mass, the size that never exceeds 5 cm in diameter, and is not completely encapsulated, and it contains cyst, mucoid material. How are the tumor of high grade malignancy? They will be rapid growing, they will involve facial nerve palsies, there will be trismus, drainage of ear, difficulty in swelling, and involves numbness of adjacent areas and ulceration. And it may metastasize to the regional lymph nodes. There may be distant metastases to the lung, bone, brain, and subcutaneous tissue that are more common. Now, what are the histological features? Three types of histological appearance could be seen. That could be mucus secreting cells, epidermoid type, or intermediate type. Based on the grading, they can be classified into low grade, intermediate grade, or high grade. The low grade, they show well-formed glandular structures and prominent mucin-filled cystic spaces, minimal cellular atypia, and high proportion of the mucous cells. Whereas the intermediate grade tumors, they have solid area of epidermoid or squamous cells with intermediate basaloid cells. Cyst formation is seen but is less prominent than in low grade tumors. Whereas the high grade tumors, they consist of solid nest and cords of intermediate basaloid and epidermoid cells. They show prominent nuclear pleomorphism and mitotic activity that is present. The treatment is always conservative. That involves preservation of the facial nerve. If possible, that is the recommended for low and intermediate grade mucoepidermoid carcinoma of the parotid gland. The affected submandibular gland, that should be removed completely. Radicular neck dissection is performed in patient with showing the clinical evidence of cervical nodes metastasis and is considered with the T3 lesions. Postoperatively, radiotherapy and chemotherapy may be used. The next comes the adenoid cystic carcinoma. The other name of adenoid cystic carcinoma is cylindroma. Which carcinoma is known as cylindroma? It's adenoid cystic carcinoma. It is a slow growing but aggressive neoplasm with the remarkable capacity for reoccurrence. It is characterized by proliferation of ductal and the myoepithelial cells. So two cells, one are the ductal cells and other are the myoepithelial cells in the cribriform, tubular, solid or cystic pattern. What are the features of this adenoid cystic carcinoma? Which salivary glands are most commonly involved by this tumor? They are the parotid, submaxillary and accessory glands in the palate and tongue. The adenoid cystic carcinoma, it occurs most commonly during the 5th and 6th decades of life. It is seen more commonly in the females. Many of the patients will exhibit clinical manifestation of malignant salivary gland tumor, showing the symptoms like there could be early local pain. Patient may complain of facial nerve palsies in the cases with the parotid tumors. It may show fixation to the deeper structures and one may see invasion. This adenoid cystic carcinoma, it has a marked tendency to spread through perineural spaces and usually invade well beyond the clinical apparent borders. What are the histological features of this carcinoma? It is composed of, we discussed just before that it is composed of two types of cells. What are those? One is the myoepithelial cells and other are the ductal cells. And morphological, three growth patterns that could be seen. The cribriform, which one is the classic form, the tubular and solid form. The cribriform pattern that will show basaloid epithelial cells that forms multiple cylindrical cyst-like pattern that resembles a Swiss cheese. That will resemble a Swiss cheese or honeycomb pattern, and is the most classic and the best recognized pattern. So the Swiss cheese type pattern, it is the characteristic feature of which tumor, which carcinoma? It is the adenoid cystic carcinoma. The tubular pattern, it will contain tubular structures that would be lined by stratified cuboidal epithelium. The solid pattern, that will show solid group of cuboidal cells with little tendency to either duct or cystic formation. Which pattern is most common? It's the cribiform. Which is the least common? It's the solid form. The treatment of adenoid cystic carcinoma is chiefly the surgical, is the excision. Radiotherapy, we can give radiotherapy, high grade malignancies. The next is the adenocarcinoma. It is the rare neoplasm of the salivary glands, but aggressive and are most common to the intraoral minor salivary glands. So, which carcinoma is most common to the intraoral minor salivary glands? It's the adenocarcinoma. It is seen in 40 years of age. Male and female has equal tendency to spread. It is seen in 50% cases in the parotid gland. Intraoral minor salivary glands are the next more affected size. Only 25% patient complains of pain and facial weakness. The histological features are, it consists of firm mass with irregular borders and infiltration into the surrounding tissue. It has a wide range of growth pattern that is difficult to classify. Based on that, they can be, based on the degree of cellular differentiation, it can be classified into grade 1, grade 2 and grade 3. Grade 1 are well formed ductal structures. The treatment, it is aggressive, complete local excision. One may have to sacrifice facial nerve, and in minor salivary glands, portion of maxilla or mandible is to be resected. Post-operative radiotherapy is useful. Lymph node metastasis may also be found.